Yeah, so some of the historical regimens that were used prior to some of the new agents being brought to market were high-dose combination therapies. So this could include carbapenems, polymyxin-B, colistin, tigecycline, etc. But in 2015, ceftazidime avibactam was brought to market that has shown to be effective for KPC producing CRE, and then in 2018, meropenem, vaborbactam. And since then, some newer agents as well have been approved, such as plazomicin and avibactam. So we wanted to look at the clinical outcomes between ceftazidime avibactam and meropenem vaborbactam for treatment of CRE infections, because previous studies have shown that each agent is superior in terms of safety and efficacy for treatment of CRE infections when compared to some of those older regimens that I talked about, but direct comparison between the agents is lacking in the Tango 2 trial that showed meropenem vaborbactam was safe and efficacious for CRE infections. There was only one patient that received ceftazidime avibactam. So our primary endpoint was clinical success, and some of our secondary endpoints were 30 and 90-day mortality, adverse events, hospital and ICU length of stay, and recurrence of CRE infections. And as terms of clinical success, we didn't find any difference. Both ceftazidime avibactam and meropenem vaborbactam had a clinical success rate around 60%. And then we also didn't see any statistically significant differences in the secondary endpoints. We did find a few surprising elements to our study. We did look at how often combination regimen was used in each arm, and we found that ceftazidime avibactam was used in combination with other agents 63% of the time. So these other agents included tigecycline, colistin, polymyxin-B, and aminoglycosides. So as you can imagine, these are pretty toxic drugs. And as a result, we found a statistically significant increase in adverse events in the ceftazidime avibactam group, and this was primarily driven by nephrotoxicity. Yeah, so we concluded that although clinical success was similar between the two agents, that meropenem vaborbactam may be preferred as it can be used as monotherapy. Combination regimen, as we saw with ceftazidime avibactam, does have an increased risk of adverse events.